Okay. So what I was going to remind students is that nowadays, when I input the grades, I'm asked to input a numerical value, not a letter. So I'm not putting A's and B's and C's. I'm actually putting 84% or 91%. That's what I'm putting in. So that's what's being recorded. I believe in the transcript, you're still seeing letter grades, but I just wanted students to know that what is being recorded by the registrar is a letter. A number. And I think that may be more relevant to dual credit students, high school students who are taking a class like this, because they're the ones who need a number. But nonetheless, if that is important, and let's say you have an 82 right now and you still maybe have a few more things to do, and you say, well, I wanted a B and 82 is a B, you need to understand that if it's significant to you, an 89 versus an 86 or an 87 versus an 82 may make a difference if that's significant to you. Okay, I just wanted to make that point. For whatever reason, that's what we're doing nowadays. We're entering numbers, not letter grades. Okay, so just wanted you to make aware of that. All right. So, okay, so pathogenic bacteria, essentially what I have in these PowerPoints, I divided into gram-positives and gram-negatives, and the gram-positives is a, let's see, I've chosen the bacteria that most commonly cause infections, more likely to encounter in the course of your professional careers. And this is a compilation of information from several of the last chapters of the book. Okay, so one thing, first of all, is we're going to deal with the genus Staphylococcus, which is one of the most important, medically important genus out there. And many of the members of the genus, many of the species, are normal flora in the human body, but they can also be opportunistic pathogens. They're all these. Staphylococcus is a gram-positive cocci arranged in clusters. Definitely need to know these. They're non-motile. We have talked about these in chapter 4, that this was a genus that was halotolerant. They tolerate salt, which also means they tolerate dry environments, which allows them to survive in fomites, which is part of their pathogenicity. They're facultative anaerobes. We mentioned these in chapter 4 also. They're catalase positive. We mentioned this in chapter 4 also. They're pyogenic, meaning they cause pus. Okay, there's a little picture of Staphylococcus. There are two species that are significant, Staphylococcus aureus and Staphylococcus epidermidis. We're not going to talk about Staphylococcus epidermidis other than to say they're normal microbiota in the human skin. We talked about that in chapter 16. Staphylococcus aureus, however, is probably the more important. Some of the strains are pathogenic. All of the strains are opportunistic pathogens. They are normal microbiota of the skin and the GI tract, and some strains are more virulent than others. So this is a common cause of nosocomial infections. We saw that in chapter 19. It is a facultative anaerobe, and we saw these actually in the lab, that these Staph aureus can ferment mannitol, and this is the basis for identification in the lab. We do a mannitol salt agar plate, MSA plate, and that allows us to grow and identify Staph aureus because of its resistance to salt and its ability to ferment mannitol. It has a low infective dose that is part of its pathogenicity, so a few bacteria can cause an infection. Now, the pathogenicity results from many attributes that the bacteria have. Pretty much all strains are going to have a protein A, which is, we'll talk about it here in just a second, capsules. Leukocidin, cidin means to kill, so these are enzymes that kill leukocytes, white blood cells. Coagulases, this is an important enzyme because it's unique to Staphylococcus aureus, this right here separates Staphylococcus aureus as a pathogenic organism from other Staphylococcus. You can also have hyaluronidases, which hyaluronic acid is a component of connective tissue, which means it can destroy connective tissue and invade deeper tissue. Staphylokinases, these are enzymes that create clots. And then some strains, many strains actually, have an enterotoxin, which we saw in chapter 16 as a form of exotoxin that was a superantigen and caused food intoxication. It's a very, very common toxin. And this is just a look at the cell wall of the bacteria. Actually, this is the cell membrane. This will be the cell wall. And then you have some of these proteins that stick out. Protein A right here. Actually, I think this is protein A right there. And then this is the coagulase enzyme sticking out. So a lot of these enzymes that give Staphylococcus its pathogenicity are sticking out of its cell wall. Protein A is unique to Staph aureus, and it's a very important protein. We're going to talk about it, and we have already talked about it in chapter 16 as an Fc receptor. So an Fc receptor is a protein that binds to antibodies. So binds to the constant region of the antibody, preventing the variable region, from which is the one that should be binding to the bacteria, preventing it from binding to the bacteria. And by doing these, it prevents phagocytosis. It inhibits phagocytosis because the phagocytic cell, this was from chapter 16, is supposed to attach to the Fc region and then eat up the cell. If the Fc region is otherwise taken by the bacteria itself, and this is a very clever strategy, the bacteria itself grabs a hold of the Fc region, so now it is not available for the phagocytic cell to bind to it, and now the phagocytic cell cannot eat up the bacteria. So that's a very important pathogenic factor in Staph aureus. It helps it evade phagocytosis. Incidentally, protein A also does other things. It allows the bacteria to bind to von Willebrand factor, which is a clotting factor present in blood. And with that, it can attach to surfaces, like coating catheters, for example. They allow the protein A allowed the bacteria to bind to each other, creating biofilms. Protein A also binds to some antibodies and kills B cells by these protein A antibody B cell binding. Protein A also binds to receptors in epithelial cells of the airways and makes these cells secrete cytokines that cause inflammation. So protein A does a lot of things. We're only focusing in one of its features, which is being an Fc receptor. But just to show you that this is more than just an Fc receptor. It's been called the Swiss knife of proteins for Staph aureus because it can do so much stuff for the bacteria. All right, some of the Staph aureus also have a polysaccharide capsule that protects the organism from phagocytosis. Leukocidins, which destroy white blood cells, especially neutrophils. Coagulase, very, very important because it's unique to Staph aureus. The minute you detect coagulase, you know you have a Staph aureus. And coagulase, like the name implies, it's an enzyme that creates clots, blood clots. So the way they test for the enzyme is they take a little test tube with rabbit plasma and they add the bacteria to the rabbit plasma. And in a matter of hours, maybe 8 hours or so, the enzyme would have clotted the plasma versus no clot, which means no Staph aureus. So coagulase, the presence of coagulase tells you have a Staph aureus, and not only that, but you have a pathogenic strain of Staph aureus. Hyaluronidases breaks down hyaluronic acid in connective tissue, allowing the bacteria to go through deeper tissue. Staphylokinases dissolve clots. So notice that the bacteria has both enzymes. One enzyme that makes the clot, another enzyme that breaks down clots, which makes it very versatile. It has lipases, which break down lipids. This one is another incredibly important enzyme that some Staphylococcus aureus may have. These are called beta-lactamases. And beta-lactamases are enzymes that inactivate a class of antibiotics called beta-lactam antibiotics. Examples of beta-lactam antibiotics: penicillins, cephalosporins, imipenems, clavonolate, which are very important groups of antibiotics. So that's what makes these bacteria resistant to so many antibiotics, are these beta-lactamases. And there is the beta-lactam ring destroyed by beta-lactamases. We mentioned leukocytins, which destroyed white blood cells. All right, on top of that, some strains of Staph aureus have superantigens. We've already talked about the enterotoxin superantigen, which is present in at least half of the strains of Staphylococcus. This is a toxin that causes food poisoning, vomiting, diarrhea, nausea. And essentially what a superantigen is, give me just a second. This is, I'm trying to see what the bacteria, okay. Okay, so what it does, so this is the bacteria with a superantigen that allows it to connect a T cell with a antigen presenting cell in the absence of an antigen. So sorry, this is the antigen right there. So this will be an antigen. So this is what it should be happening. This is the normal occurrence. A superantigen, which in this case will be something that will be attached to the bacteria. So if this is the bacteria, the superantigen is attached to the bacteria. It brings together the T cells and the antigen presenting cells, causing disconnection in the absence of an antigen. So in the absence of a reason for these cells to mount a response, these cells begin to mount a response, creating a cytokine storm. In the case of the enterotoxins, the immune response is localized to the GI tract. So it's bad, but it's not as bad. In the case of the toxic shock syndrome toxin, is a systemic immune response, which now you have something that could be deadly. All right, other toxins that these bacteria, Staphylococcus aureus, can have, an exfoliative toxin. An exfoliative toxin causes something called a Staphylococcal scalded skin syndrome, which essentially causes the cells in the epidermis to begin separating from each other, and they begin to peel off. Looks like a really bad sunburn, but it's actually a staphylococcal infection. So the most common kind of infection that the bacteria causes is going to be cutaneous infections. So your common impetigo, furuncles, carbuncles, Staphylococcal scalded skin syndrome. This is some of the, most of the skin infections are going to be caused by Staph aureus. Non-invasive Staphylococcus can also cause that enterotoxin food poisoning we talked about. That's also very, very common. This is less common, thankfully, because it's more serious, a systemic disease: bacteremia, endocarditis, toxic shock syndrome toxin. So again, most common infections will be cutaneous diseases. So 70% of the skin infections are caused by Staph aureus. Examples of these kinds of infections: impetigo, folliculitis, cellulitis, carbuncles, furuncles. For the most part, you're going to have pus because Staphylococcus bacteria causes pus. So impetigo, it's an infection of the epidermis of the skin, surface skin infection. Cellulitis is an infection of the connective tissue, so the dermal tissue, the dermis of the skin versus the epidermis for impetigo. Furuncle is a hair follicle and sebaceous gland that's infected. Carbuncle is the infection of many furuncles together. So we've all dealt with one of these at one point or another. Systemic diseases, those are more serious. Toxic shock syndrome toxin. We talked about these in chapter 16. It's a superantigen. You have abrupt onset of high fever, vomiting, sore throat, muscle pain, a rash very quickly. And that could progress to shock, and that should say shock, not shock, renal and cardiac failure, which is really what is deadly. This is the condition, the syndrome that was associated with highly absorbent tampons. Other systemic diseases that Staphylococcus aureus can cause: bacteremia, endocarditis, pneumonia, osteomyelitis, especially in children. Staphylococcal scalded skin syndrome. This is a skin infection. We mentioned before, we have the redness, we'll have fever, the skin peeling, and this is caused by the exfoliated toxin. Very contagious. It's seen mainly in children, especially in nurseries. Diagnosis and treatment of staphylococcal infections. We could isolate the organism from pus or other body fluids. Treatment, antibiotics. If the organism is not resistant, it is easier to treat. However, nowadays, many of the staphylococcus we're dealing with are resistant to methicillin, MRSA, methicillin-resistant Staph aureus, in which case you have to recourse to stronger antibiotics. Things like vancomycin, linezolid, which is Cyvox, rifampin, sulfa drugs, trimethoprim, doxycycline, minocycline. Most of these have to be given in a hospital. We also have vancomycin intermediate Staph aureus, so aureus that may not respond to vancomycin as well as it should, and we have even isolated vancomycin-resistant Staphylococcus aureus. So you should know what these acronyms mean. In this case, now we have to recourse to even more strenuous antibiotics like Sinusit and Cyvox, which definitely have to be given in an IV mode. Prevention, difficult hand washing is one of the most sure ways. This is a nosocomial, many of these can be nosocomial infections. Use of appropriate aseptic techniques. So have an idea of what these enzymes and toxins that make these organisms pathogenic are. The next organism is the Streptococcus, which is a genus that is closely, it's not related, but it's similar to Staphylococcus. Dr. Rebecca Lansfield, she worked with identifying Streptococcus in the 1950s. And her work was solely on classifying Streptococcus using antibody tests. So she put together a classification for Streptococcus using antigens. So we have antigen groups, and we use what we call the Lansfield groups of Streptococcal classification. Medically, that's what we use. So Streptococcus are gram-positive cocci, just like Staphylococcus are. Their shape is sometimes a little bit more ovoid than round. Their arrangement is pairs or chains versus Staphylococcus, which is clusters. Staphylococcus was a facultative anaerobe. Streptococcus are aerotolerants, which means they have no catalases they only have superoxide dismutases. So this is one feature, the catalase, that separates Streptococcus and Staphylococcus. Also the oxygen requirement. These are only fermenters, that is their only metabolism, which tells us that it really makes them grow, they grow very slowly. So we classify by the Lancefield groups A and B, which are the most medically significant ones. And then some Streptococcus do not have a Lancefield group. Okay, so Streptococcus pyogenes is the genus and a species to the Lancefield group A Streptococcus, which also has the acronym GAS or GAS. This is a beta hemolytic Streptococcus, meaning it's going to hemolyze destroyed red blood cells. It is very pathogenic. Many of the strains have capsules. It is normal flora in the throat of about 5 to 15% of the population. And the medical community has been working very hard to try to lower this number of carriers of the organism, because the organism is ultimately very virulent. There is a rapid strep test that was developed many years ago that allows us to identify streptococcal throat infection very, very quickly. So if somebody has a throat infection that they suspect is a strep throat, they can go to the doctor and have these tests done, and within a matter of minutes, they will know whether they have group A strep or not. So this test detects carbohydrate A in the bacterial cell wall. That's the antigen that's detected by the antibody. So the group A Streptococcus forms short chains. The organism is cocci, but it does have a little bit of an ovoid shape. It's beta hemolytic. And again, this is the little short chains. It's a gram-positive organism. The organism is virulent, but it doesn't compete very well with our normal flora. So as long as we have a good normal flora, the organism cannot cause much harm. It is when the normal flora is depleted, or if we're exposed to a large number of the organism, that we're in trouble. Or obviously if we have problems with our immune system. Pathogenicity is due to many different factors. Some of the strains have M proteins, which we talked about in chapter 16, which is a protein that breaks down C3b, and that prevents opsonization, and with that, it prevents phagocytosis. Hyaluronic acid capsules, this is a very unique feature that some of the strains have. This is a capsule made of the same component as found in our connective tissue. So our immune system does not see these as foreign, it sees it as self and leaves it alone. So it's a very clever way to camouflage the cell. Protein F allows the bacteria to attach to host cells. Protein G is the equivalent of protein A in a Staphylococcus. It's an Fc receptor that interferes, again, with opsonization. So this is some of these proteins that stick out of the cell wall of the organism. Enzymes, other enzymes, we talked about hyaluronidases, I think, DNases. This one is unique to Streptococcus, or at least very few organisms have enzymes that destroy DNA the way on the surface of the cells. Streptolysins, this is the equivalent of the hemolysis. This is going to lyse red blood cells, and this is responsible for the beta hemolysis that the organism has. CA peptidases, this is going to destroy C5a, preventing phagocytics from being called on to the area of infection. Streptokinases breaks down clots. This is the equivalent of staphylocinases in Staphylococcus. As far as toxins, exotoxins, a toxic shock syndrome toxin can also be made by Streptococcus pyogenes, or group A Streptococcus. These organisms also can have necrosiding fasciitis toxins. We'll talk about this in just a second, and erythrogenic toxin, which causes scarlet fever. So some of these toxins that organisms can have. The organism causes pharyngitis or strep throat, which is a serious infection in the sense that this is a very virulent organism and it has to be treated as soon as possible. This is also the organism responsible for scarlet fever. The erythrogenic toxin right here is what will cause scarlet fever. Other diseases caused by group A Streptococcus, otitis media, pneumonia, sinusitis, skin infections like impetigo, cellulitis, pyoderma. So these two, impetigo and cellulitis, can also be caused by Staph aureus. More commonly caused by Staph aureus, could also be caused by group A strep. Streptococcal toxic shock syndrome toxin we talked about. So Streptococcus also has its own version of the toxic shock syndrome toxin that we find in Staphylococcus. Necrotizing fasciitis or myositis. This is what we call flesh-eating bacteria. So some of the group A strep are able to produce these toxins that completely destroy and invade tissue. So this is an invasive wound infection. It is rare. You typically get it through some type of puncture wound in which the organism is introduced into the skin. You get sudden pain, swelling, fever, confusion, shock, destruction of fascia of the tissue. It requires immediate treatment because all of these symptoms progress very, very quickly within a matter of hours. The organism that causes necrotizing fasciitis has a whole host of proteins and enzymes that destroy tissue. Protein F, hyaluronidases, streptokinases, DNases, streptolysins. On top of that, exotoxin A, which causes fever, a superantigen, which destroys tissue, and a superantigen that activates T cells. So it's a combination of all of these features that causes that really, really fast invasion and destruction of tissue that is characteristic of the flesh-eating bacteria. Okay, so essentially what we call flesh-eating bacteria is this uncontrollable immune response and inflammation that is going to be destroying tissue very quickly, ultimately causing a decrease in blood pressure and shock. So the treatment is going to be the removal of the skin to try to prevent the continued invasion of the organism. Obviously antibiotics, but debridement and amputation in some cases is sometimes necessary. There is no vaccine. Protein M may be studied as a potential vaccine. I skipped over the little PowerPoint that had the picture of some of the other infections that group A strep can cause. Impetigo, and this one is impetigo with a lot of pus. So if you go back and look at the picture of impetigo with the Staph aureus, you don't see as much pus as you see with an impetigo caused by group A strep. Scarlet fever, there's the scarlet fever rash. Strep throat, those are the characteristic strep throat lesions. Scarlet fever is also characterized by a red tongue. Okay. Strep throat, we have fever, enlargement of lymph nodes, red throat, tonsillitis, pus fill lesions, transmitted through inhalation or ingestion. Nasal carry, yeah, the organism is a human pathogen. So there's people that carry the organism in their noses and in their throats. Again, about 5 to 10% of the population carries the organism. Now, the good news is, two good news. First of all, this is an aerotolerant organism, very sensitive to the environment, to changes in the environment. A slow grower, it's an aerotolerant fermenter, so it doesn't grow very well. It's all it does is ferment, so it doesn't make very much ATP for metabolism. It doesn't compete well with normal flora. So those are the downsides or the upsides from our point of view. Also, the organism has remained, thankfully, very sensitive to antibiotics. This is one of the few organisms that is still sensitive to penicillin, or erythromycin for that matter. However, it's still a very virulent organism. So a strep throat needs to be diagnosed as soon as possible and treated as soon as possible, because the problem with the organism is that it has what we call sequelas, the sequelas of untreated strep throat. These are conditions that could arise days, weeks, or months after an untreated streptococcal infection, strep throat infection. These are autoimmune conditions, rheumatic fever, which is an inflammation that ends up damaging the heart. This is one of the #1 causes of heart problems in young people. It is rare in the US because we have been very aggressive at treating strep throat. So it's more common in other countries. The other sequela of an untreated strep throat is glomerulonephritis, which again is an inflammation and autoimmune condition that in this case attacks the kidneys, the glomerulus and the nephron of the kidneys. Okay, so it is an after infection. It's a condition that happens after a streptococcal skin infection. So there is group A strep. Another streptococcus we're going to talk about briefly is the Streptococcus pneumoniae, which does not have a Lancefield group. This is a normal flora of the throat. It is the most common organism that causes pneumonia. It's called community-associated pneumonia. It's called pneumococcal pneumonia. It's called typical pneumonia. So it has many different names: community-associated pneumonia, typical pneumonia, or pneumococcal pneumonia. Obviously, gram-positive cocci, it is a Streptococcus in chains or pairs. It's a catalase negative, as all the Streptococcus. The organism is alpha hemolytic versus group A strep, which is beta hemolytic. It normally lives in the mouth and the pharynx of most people. It is when it travels through the lungs that it may cause problems. The diseases are more prevalent in children and the elderly. Symptoms of pneumonia start out as a cold, runny nose, upper respiratory congestion, cough, fever, chest pain, which may progress to hypoxia, shallow breathing, dyspnea, accelerated respiratory rate. Okay, the pathogenicity of the organism is only one, actually. It is mainly the capsule. It is a capsule that interferes with C3b opsonization. That's it. That's all it has. It does have adhesins that allows it to bind to the epithelium of the pharynx, but more importantly, it is the capsule. There are 2 strains of the organism. The non-encapsulated strain is not pathogenic. The encapsulated strain is the one that causes problems. It causes an inflammatory response in the lungs. It may have pneumolysins that destroy epithelial tissue in the lungs. Diseases caused by Streptococcus pneumonia, pneumococcal pneumonia. It's septicemia, endocarditis. This is one of the causes of meningitis also. So there's 3 common causes of meningitis: Neisseria meningitidis, Haemophilus influenza, and Streptococcus pneumonia. It's a common cause of sinusitis and otitis media. And diagnosis will be through growing the organism, or there is an antibody antigen reaction that looks for the capsule, and that also confirms the presence of the bacteria. Treatment, again, Streptococcus have remained, thankfully, sensitive to antibiotics. So penicillin or erythromycin. We do have a vaccine, which is made from the capsule. We talked about this in chapter 18. It does not give long-lasting immunity in children or the elderly. And again, it's normal flora. So pretty much all of us have the non-encapsulated version of the organism. 30% of the population carries the encapsulated pathogenic version of the organism. And there's a normal versus fluid-filled pneumonia lung. And then finally, we have Mycobacterium tuberculosis, which is a gram-positive rod. It was also called the bacteria. Has also been called the tubercle bacillus or Koch bacillus. This is a strict aerobe, rod-shaped bacteria. Is the causative agent of tuberculosis. Humans are the only reservoir, just the same for Streptococcus, pyogenes, and Streptococcus pneumonia. What makes the organism pathogenic is the cell wall, which has mycolic acid, that waxy cell wall we talked about at the start of the semester. The cell wall makes the organism a slow grower, a slow diffusion of nutrients, which also means a slow diffusion of antimicrobials. So the treatment is very, very long. It has a generation time of 16 hours versus 30 minutes, which is what a normal bacteria will have. Resistant to drying, resistant to acids and alkalis, again, because of the waxy cell wall. Tuberculosis is the respiratory disease caused by the organism. It is a pandemic all over the world. About 1/3 of the world's population is affected each year. So just think about that. It is millions of people that die of tuberculosis every single year. It is an unspoken pandemic. It's truly devastating. It says the cases are on the decline in the US. That depends on year to year. However, it is not rare. I mean, it is within this year. I've known of 2 people who have one of them is still latent tuberculosis. So no, this is in a medical world, this is something you will definitely see. Okay, so this is what happens with tuberculosis. The organism first causes a primary infection, which is typically asymptomatic. And this initial infection is going to be a battle between the patient's immune system and the bacteria. If the immune system controls the infection, it may eliminate the infection, in which case it's gone, that's the end of it. Or it may arrest the infection, in which case the infection becomes latent. A latent tuberculosis infection, you could think of it as a silenced one. It is still there, but it is being controlled. Versus active tuberculosis, which may develop from a latent tuberculosis years later. So the problem of a latent tuberculosis is, yes, you're not having any signs and symptoms, you're not contagious, but the organism is there, and it's just a matter of time before it becomes active. Signs and symptoms is slight fever, weight loss, night sweats, persistent productive cough, sometimes with blood-streaked sputum. So this is These are the signs and symptoms of an active infection. We get the organism through the respiratory tract. It is inhaled. It's a true airborne transmission through respiratory droplets. The organism is phagocytized in the macrophages of the alveoli of the lungs. We saw this in chapter 16. It prevents phagosome-lysosome fusion. So it remains inside these macrophages, creating an early tubercle lesion. So what's going to happen initially is that we're going to have these macrophages that are infected with the organism, and other immune system cells begin to encircle the infected cells. And that creates what's called a granuloma lesion, which can be seen in an X-ray. This is your latent tuberculosis, and these could remain there for years. If the infected cells become more active and begin to infect the surrounding cells and eventually break off and invade further tissue, now you have an active tuberculosis case. Okay, so this is the early tubercle formed by the infected macrophages and other white blood cells that surround the infected macrophages. So this is the early tubercle development, which is called a Ghon-Fossey or a Ghon complex. A complex is if it appears also in lymph nodes. So the bacteria is surviving. It may not multiply, but it's still there. So this is your latent tuberculosis. The patients are not contagious. They show no signs or symptoms. The organism is not detected in the sputum. Sometimes lesions are seen, sometimes they're not seen. It says here that no lesions are seen on X-ray. That sometimes is not true. Sometimes the lesions can be seen. However, the patient will have antibodies against the bacteria because the bacteria is being fought off by the immune system. So a tuberculin test, which is the skin test, will be positive. Remember that this is an immune system response here, which is keeping the infection at bay. T cells are going to stimulate macrophages into secreting cytokines, which are hopefully going to kill the bacteria. This walling off of the granuloma lesion is what we call the Ghon-Fossey. We talked about that. All right. Now, if the bacteria becomes active, macrophages die, releasing the bacteria, and now we begin to see dead tissue and a spread of the tissue. Now we call it caseous necrosis. This definitely can be seen in an X-ray. This is an active tuberculosis. The organism now is seen in the sputum. The patient is contagious, and you definitely have lesions on an X-ray. So there is a advanced tuberculosis, a necrotic tissue, actually dead tissue in the lungs. If the organism spreads even further, you may even get a tubercle cavity. The organism may spread to other parts of the body, bones, joints, kidneys. Then we call it miliary tuberculosis. Actually, the organism is a common cause of Addison's disease in some parts of the world because it spreads all the way to the adrenal glands. Okay, so that's just showing you the organism, being walled off, but now beginning to break off. The tuberculin test or the Mantoux test identifies essentially identifies antibodies. So it's either telling you that you were previously exposed to the disease, it tells you you may have a latent tuberculosis infection or an active tuberculosis infection for that matter. It could also tell you if it could be positive if you had the vaccine. It's another reason to have a positive tuberculin test. Chest X-rays allows us to identify active disease because it allows us to see obvious lesions. A sputum test will test for the bacteria. This is an antigen test, and definitely that would be, a telltale sign you have tuberculosis. Treatment. Now, this is difficult because the bacteria grows so slowly. The treatment is going to take a long, long, long time. It may take as long as 6 months to a year. There are 4 antibiotics that can be given. They're typically given in combinations, at least 2 antibiotics at a time, if possible. Isoniazid, INH, rifampin, pyrazinamide, and ethambutol. Sometimes some of the antibiotics are used prophylactically if the patient has been exposed to the tuberculosis. There is an immunization vaccine, the BCG vaccine, which is used commonly in other countries where TB is common. So patients that have had the BCG vaccine have a positive tuberculin test. Okay. So any questions about gram-positive pathogens? Okay, so I have here the PowerPoint for gram-negative pathogens. And this is the deal with gram-negatives. All of them, due to the presence of lipid A in their cell walls, are more pathogenic than gram-positives, just because every one of them have lipid A. So this is the largest group of human pathogens, or you could even say opportunistic pathogens, because of lipid A. Okay, so right off the bat, any gram-negative has lipid A, it has the endotoxin, is a bit more pathogenic, or it has that pathogenicity that is not found in gram-positives. Streptococcus pyogenes is more pathogenic. But all gram-negatives have lipid A, so all gram-negatives could be considered potential pathogens, which we cannot say that of all gram-positives. So lipid A is a paragen, dilates blood vessels, which that will cause low blood pressure, causes inflammation, shock, disseminated intravascular coagulation, so clots. So any gram-negative that can breach the skin or mucous membranes can cause and can grow at 37 degrees centigrade and can evade the immune system, can cause disease in humans. So we're going to start with a gram-negative cocci, the genus Neisseria. This is the only gram-negative cocci that regularly causes disease in humans. The organism is non-motile, it's an aerob, arranged in pairs. It's fastidious, which means difficult to grow outside the human body. And that is good news for us because that means that it will be difficult to spread. It is oxidase positive, gram-negative cocci. We're going to look at 2 species, Neisseria gonorrhoeae and Neisseria meningitides. Both of them can grow inside white blood cells, and that is one of the telltale signs. Take a look at the arrangement. It's in D+. So the organism actually has a bean. It is called a cocci, but it's a bean-shaped cocci. And it is when we find these bean-shaped pairs of bacteria that we know we're dealing with Neisseria, especially if we find it inside white blood cells. So Neisseria gonorrhoeae causes gonorrhea, which is a sexually transmitted disease, or STD. The pathogenicity is because the organism is able to adhere to epithelial cells of mucous membranes, and that can be nearly every mucous membrane. It can be the genitals, urinary, or GI tract. And from there, it can spread into deeper tissue. So the bacteria has adhesins that allows it to attach to our mucous membrane cells and spread from there. They're becoming resistant to antibiotics. Prevalence, we have 350,000 new cases each year, second only to chlamydia. It has an incubation of 2 to 5 days. Asymptomatic carriers are found in both sexes, but especially in females. Most females are asymptomatic carriers. Humans are the only host. Gonorrhea in men is usually symptomatic. It causes inflammation, a painful discharge, painful urination. So it may cause a urinary tract infection. Untreated, it may proceed to scar tissue, sterility, infection of the prostate or the testes, which is called orchitis. Gonorrhea in women causes gonococcal urethritis, also called GU. It is often asymptomatic, or the symptoms are mild, pain or a discharge. Most females with pain or a discharge, especially mild pain, may not pay much attention because that could be a premenstrual happening, for example. It may infect the cervix, advance to the uterus, go to the uterine tubes, and from there it could go into the abdominal cavity. It can cause pelvic inflammatory disease, or PID. It can cause ectopic pregnancies or sterility due to scar tissue. Disseminated gonococcal infection is when the organism goes into the blood and begins to travel through the body, causing fever, rash, arthritis, if it deposits itself in joints. The organism is serum resistant. From chapter 16, what that means is that prevented complement activation. So now the serum-resistant Neisseria gonorrhoeae can cause meningitis and endocarditis if it becomes disseminated throughout the body. The organism can cause ophthalmic neonatorum in children who are being born through the birth canal that's infected, and in rare complications, DGI in children also. Pathogenicity, the PLI, which allows it to attach to the mucous cell membranes, OPA proteins, which allows it to attach to the host, invades mucous membranes, pretty much any mucous membranes, but Neisseria gonorrhoeae typically invades the urinary reproductive tracts. From chapter 16, this was the example of an organism that could have antigenic variations, IgA proteases, which again protects it in mucous membranes. So enzymes that can destroy IgA, and OPA that can attach to T cells and prevent activation of T cells. Factors that influence high incidence of gonorrhea: birth control pills increase the pH of the genitourinary tract, making it more favorable for infections. So that's something to be aware of. Asymptomatic carriers, lack of immunity, so immunocompromised patients. Gonorrhea in men can be identified by examining the discharge. There's also genetic probes that allows us to identify the organism, just like we saw in lab report 8, I think it was, no, or 9, with Neisseria meningitidis. Treatment for antibiotics, there is resistance going on. So there are Neisseria, gonorrhea that are becoming resistant to antibiotics. And again, prevention, there is no vaccine, so it is the same preventions you would have for any STD. And that's just showing you the organism gaining access to a mucous membrane cell, going inside the cell, traveling to the other side, being phagocytized by a macrophage, and or by a neutrophil, and from there eliciting a immune response that is going to create cell damage that would allow other bacteria to go in. The other Neisseria is similar to gonorrhea. This one is meningitis, so meningitides. It causes meningitis. This organism is actually normal flora. Many people carry this organism as normal flora of the upper respiratory tract. That is not necessarily rare at all. It could, however, cause an infection if it goes into the blood or this central nervous system. It's the most common meningitis in individuals under 20. It is transmitted by respiratory droplets through close contact. Again, Neisseria is fastidious. It doesn't grow very well outside the body. So it is not spread easily. It can be a devastating disease. Meningococcal meningitis could cause death within a matter of hours. Signs and symptoms of bacterial meningitis, it starts like a cold, but develops into headaches, fever, pain. This one is critical, stiffness of the neck or back for that matter. But this is when you definitely become concerned. Vomiting also, deafness, confusion, loss of consciousness, coma, obviously. All these tells you don't have a common cold. This is something that it's very, very, very serious. Sometimes petechia due to the systemic shock. Remember, this is a gram-negative, so it will have a lipid A. It could cause septicemia, blood poisoning. Again, minute hemorrhages. There are several strains. But we do have vaccines for the most common strains. Pathogenicity is the same as that of gonorrhea. It has a pili that can attach to the respiratory epithelium, and then it has proteins that allows the organism to invade into further tissue. The endotoxin lipid A causes septic shock, and there may be a capsule present. As meningitis is diagnosed by examining the cerebrospinal fluid during an infection, because it will have low levels of glucose, since the bacteria is consuming the glucose. The endotoxins is what's going to lead to the shock. Also, the organism will have to be grown from CSF or from blood. So here's the problem. You have a patient that is suspected of having meningitis. So you're going to draw blood and maybe even a sample of cerebrospinal fluid and try to grow it. Two of the organisms that are most common causes of meningitis are difficult to grow. Neisseria meningitidis and Streptococcus pneumoniae are both fastidious, difficult to grow. So you're trying to grow this organism because we need the exact bacteria that's causing the infection so we can target the antibiotic treatment properly. Neisseria meningitidis is a gram-negative, Streptococcus pneumoniae is a gram-positive. You might want to use different antibiotics to target each. So you're running a race against the clock, against organisms that are difficult to grow. So that's also why meningitis is so can be so devastated. Penicillin is still obviously intravenously, effective against some of the Neisseria. Rifampin is used as a prophylactic if the patient has been exposed to the organism. There is a vaccine for the meningococcal vaccine, which is good for most common strains. Okay. The next group is not a genus, is a family, the Enterobacteriaceae family, which we first encountered in chapter 4 when we were talking about facultative anaerobes. So this is a family of gram-negative rods, which are facultative anaerobes. The name comes because many of the members are found in the intestinal flora of humans and animals. They're found in water, soil, decaying vegetation. This is the most common gram-negative pathogen of humans. It says Coccobacillus or Bacillus. They're classified as rods, whether they are little rods or normal-sized rods. Facultative anaerobes, all of them are glucose fermenters. So this is an overview of these Enterobacteriaceae rods. They all have pilosis. They may have an exotoxin. Pretty much they all have adhesins. Some have hemolysins, flagella. Some of them will have flagella. Capsules, many of them have capsules. Type 3 secretion systems, that's found in gram-negatives. This is the proteins that allows them to gain access to host cells, invade them, also allows them to prevent phagosome-lysosome fusion during phagocytosis. And then other common antigens that stick out, like the O antigen. Obviously, everybody has the lipid A also. The organisms are diagnosed by culturing them on selective and differential media like EMB or McConkey's. There are some rapid tests available to identify some of these enteric bacteria. Now, the treatment is tricky because the organism has lipid A, so you do not want to cause a massive release of lipid A. So oftentimes, there is no antibiotic treatment, just support the patient with fluids and electrolyte replacement. If antimicrobial drugs are given, typically it's going to be bacteriostatic antibiotics, not bactericidal. So antibiotics that slow down the growth of the bacteria without killing it. Because again, what we're trying to prevent is the massive release of lipid A. Prevention, hygiene, hand washing, that's really it. We classify the members of the Enterobacteriaceae family into the ones that live in the colon, called coliforms. They ferment lactose with gas production. Remember, all of them are glucose positive. So all of them ferment glucose. The non-coliforms, which are opportunistic pathogens, and then there's a small group of real pathogens, true pathogens. So CNS, central nervous system, can be invaded by Escherichia coli, lower respiratory tract, Klebsiella pneumonia, Enterobacter, Escherichia, bloodstream by, again, E. coli, Klebsiella, Enterobacter, GI tract, Salmonella, Shigella, E. coli, Yersinia, urinary tract, E. coli, Proteus, Klebsiella, Morganella. So remember, we divided them into groups, the coliforms, the non-coliforms, the true pathogens. So the coliforms, it says aerobic or facultative anaerobic. They're pretty much all facultative anaerobes. Gram-negative rod-shaped bacteria colonize the intestines of humans. We call them coliforms when they're present in water because they are indicators of fecal contaminant. So they indicate you that the water has not been treated properly. The most important member of this group of the coliforms, group of the Enterobacteriaceae family members, is E. coli. Another one is Enterobacter. And E. coli, let's see, that's a normal flora of the human colon, an animal colon. It may cause gastroenteritis. Typically is due to some exotoxin that causes the gastroenteritis. It's very common cause of UTIs. It says non-nosocomial and nosocomial for that matter. So E. coli is the most common cause of urinary tract infections. Now, E. coli 015787 is a different organism altogether. This is a pathogenic E. coli, whereas the other ones were opportunistic pathogens. This one is a pathogenic organism. It causes diarrhea, hemorrhagic colitis, so hemorrhagic meaning bleeding of the colon, which progresses to something called hemolytic uremic syndrome, which is an autoimmune condition that affects the kidneys. Most epidemics are associated with unpasteurized milk or juice or undercooked ground beef. The organism has type 3 secretion system toxins, and it has what's called a Shiga-like toxin that gives it the same symptoms as dysentery. So E. coli 15787 causes a very bad form of dysentery, plus that could progress to an autoimmune condition that affects the kidneys, the hemolytic uremic syndrome. So it's a pretty bad strain of E. coli. So we had the coliforms, the non-coliforms, and the pathogenic Enterobacteriaceae members. We talked about E. coli as the most important member of the coliform group. We're not really going to talk about the non-coliforms. Instead, we're going to talk about the pathogenic Enterobacteriaceae members. The pathogenic ones have type 3 secretion systems, with which they inhibit phagocytosis. They can travel from cell to cell, and they eventually causes the death of the cell, so they will escape. Salmonella is a pathogenic Enterobacteriaceae. It is motile, found in the intestines of reptiles and mammals and birds. And most salmonella infections can be linked to contaminated foods. There are two species of Salmonella, Typhimurium, which causes salmonellosis, and Typhi, which causes typhoid fever. When you hear of Salmonella, this is the one that we're dealing with. Is Typhimurium, salmonellosis. Typhoid fever is a much serious condition. However, there is a vaccine for it. So the organism gains access to the GI tract cells, goes inside, prevents phagosome-lysosome fusion, so it can live inside the phagosome indefinitely and replicate until it causes apoptosis of the cell, from which it can begin to invade other cells or gain access to the bloodstream and begin to travel in the bloodstream. Humans are the only host of Salmonella typhi, which causes typhoid fever. This is a serious infection, which causes bloody stools, and the bacteria can spread from the intestines into other places like liver, spleen, bone marrow, gallbladder is a favorite, because the organism will just stay in the gallbladder and become a recurrent infection. Treatment with antibiotics, judicious group of treatment of antibiotics, because we don't want the lipid A being released. Vaccines for Salmonella typhi are available, typhoid fever vaccines. The other pathogenic gram-negative rod is Shigella. Shigella is actually a non-motile. It's a human organism, whereas Salmonella was animal, Shigella is human. It produces a bloody diarrhea intoxication called dysentery or shigellosis. There are different species. Shigella dysentery is probably the worst. All of them cause the same condition. The organism is non-motile, so it is not likely to spread past the GI tract. So yes, it does invade and it spreads from one cell to the other, but if it were to try to invade the blood, it does not have good protection from actual phagocytic cells. Okay, and the last of the gram-negatives we'll talk about will be Pseudomonas, which is a gram-negative aerobic rod. Enterobacteriaceae were facultative anaerobes. This is aerobic. It is ubiquitous in the environment. It is problematic in hospitals. It is definitely an opportunistic pathogen, especially with immunocompromised patients. It is a common nosocomial infection of cystic fibrosis patients. The organism can cause biofilms which protect it from phagocytosis. But the more important thing about Pseudomonas is that it's very resistant to disinfectants and many antibiotics. So treatment is very, very difficult. Okay, so that's basically it. So we've gone through these, and basically you should know the characteristics of the organisms, the disease they cause. Make a list of the organisms for which we have vaccines. So we mentioned Streptococcus pneumonia, Mycobacterium tuberculosis, Neisseria meningitides, Salmonella typhi. Those are the 4 that we mentioned we have vaccines for. Know the kinds of infections they cause. When it comes to the gram-positives, we mentioned a lot of their toxins and their proteins and enzymes. Keep track of those. Okay, any questions? Okay, so that is it. I will post the recording as soon as it becomes available.